Yes, ma'am. In 1 minute, we will be live.
All right.
That means till for 1 minute we can gossip.
No. We all have to be on mute.
मैम एग्जैक्टली पता नहीं चलता है और ये सारी गॉसिप लाइव चली जाती है.
I know.
Dr. Manisha, you need to adjust the light in front of your face. पीछे ज्यादा लाइट है, सामने कम है.
Okay, ma'am.
We are live now. Good evening, everyone, respected faculties and all the delegates who have joined. I welcome you all for the 185th edition of Happy Learning Masterclass webinar series in association with Bhandara, Chandrapur and Nagpur Society. Theme for today's webinar is Mixed Bag. Convener for today's webinar is Dr. Asha Jain. She is past president, Raipur OBGY Society. Dr. Asha Jain is MD, DNB, MN, AMS, MBA, FICOG, FIC, MCH.
Abhishek, you can make it small. I hope everybody knows me here.
Okay, ma'am. Just 2 lines about you, ma'am. That you are the director of SMSA Hospital Raipur, and your center is you are having 32 years of experience, and your center is Foxy recognized center for ultrasound training and colposcopy training. I welcome all the delegates and faculties, and please join for lamp lightning for the opening of the session. Thank you so much all. Ma'am, over to you for further proceedings.
Thank you, Abhishek. So, namaskar and welcome everyone. For the formal welcome address, I would invite Dr. MC Patel, sir, the director of this program, whose brainchild is this Happy Learning series, reaching 185. That is more than we can even think about. So over to you, sir, for the formal welcome address.
Thank you, Dr. Asha. It gives me immense pleasure to welcome you all on 185th episode of Happy Learning Masterclass web series. I welcome Dr. Sulba Joshi Madam, who has kindly consented to be chief guest to bless the webinar. I also welcome Dr. Radhalakshmi Sadras Madam from Chandrapur. She has kindly consented to be guest of honor to bless the webinar. And Dr. Lakshmi Srikhande, she has also kindly consented to be guest of honor to bless the webinar. I also welcome Dr. Chaitanya Sambekar, not less than my younger brother. Chaitanya is kindly consented to deliver a very interesting talk, HDU setup in modern obstetric, how to set up HDU, and to chair that very important session. I invite 3 learned chairpersons, Dr. Kshama Kedare, Dr. Varsha Daule Madam, and Dr. Ritu Dargan, all from Nagpur. I also welcome all learned panelists who are going to bombard question in a panel. This is reverse panel. They are going to ask question, and being a moderator, I am going to answer. And topic is legal issues in high-risk pregnancy. So I welcome all the panelists. Dr. Bharat Langewar sir from Bhandara, Dr. Manoj Agavle from Bhandara, Dr. Manisha Vasade from Chandrapur, Dr. Sushma Deshmukh from Nagpur, Dr. Pragati Kalatkar from Nagpur, Dr. Priya Sinde from Chandrapur, Dr. Sandeep Nikhade from Nagpur, Dr. Meera Agalwe from Bhandara, Dr. Vaidehi Marathe from Nagpur, Dr. Alka Mukherjee from Nagpur, Dr. Sarmili Poddar from Chandrapur, Dr. Rujuta Phuke from Nagpur, Dr. Kirti Sane from Chandrapur, Dr. Mosmi Taras from Nagpur, and Dr. Priyanka Kamble Madam from Nagpur. I also welcome Dr. Asha Jain. She is convener for this series since long. So welcome Dr. Asha, and two coordinator, Dr. Rekha Ranjan Kumar from Bengaluru. She is President-elect of Bengaluru OBGYN Society. She is coordinator in this series since long. And Dr. Manisha Ghate, President Chandrapur OBGYN Society. She is one more coordinator for today's webinar. Manisha has taken lots of pain, not only to design this program, but to execute this program as coordinator. So welcome, Manisha, and thanks for all the support, help you have made for this webinar. In era of COVID-19, I started this series with 3 friends, and now it has become more than 7,000 plus member family as far as this Happy Learning Masterclass web series is concerned. So we usually discuss focus topic, and now in this 4th series, because we have completed 3 rounds of all the Society of Foxy. This is our 4th round, even with Nagpur, Bhandara, and Chandrapur. This is our 4th round. So in this series, 4th round, we have started reverse panel. So in that very panel, we discuss focus topic, and panelists ask question, and being a moderator, I answer all those questions. So with this short welcome, I welcome all the President and Secretary of Joining Society and all the delegates who have joined this webinar. Thank you very much.
Thank you, sir. Abhishek ji, may I have the CV of Manisha Ghate ma'am, please? So I welcome our coordinators. Dr. Manisha Ghate ma'am is the president of Chandrapur Society. She is the West Zone Coordinator, Food Drug Medico Surgical Committee, Foxy, Secretary General ISOPAB Vidarbha, Chairperson Women's Doctors Wing IMA, Secretary of Chandrapur Society previously, Vice President IMA Chandrapur 2019.
Yes, madam. Yes, let it be now. Thank you for the
Thank
kind
you.
introduction.
Thank you. Welcome, Dr. Manisha. And we would like to hear a few words from you about your experience with this webinar.
Yes, ma'am. First of all, good evening to all the respected seniors and dear friends present here. As a coordinator of this episode of Happy Learning Masterclass, which is the 185th edition, I wholeheartedly welcome you all for this most happening event. This series of Happy Learning Masterclass, it is the brainchild of our respected Dr. MC Patel, sir. Sir, we have always admired you for your exceptional work, which is a shining example of dedication and excellence both. Your contribution in the Foxy, and that too in the medical legal field, is highly applaudable. You are one of the best team leaders who have always been on front foot to guide and bind together all to make a teamwork happen. You are one of the most approachable person who is anytime ready to help the members if any untoward situation arise within the members. And this make you stand specially noticeable from the others in the crowd. Our best wishes are always with you, sir, for your further journey. Thank you once again for including me as a part of this webinar series. Thank you, Asha Madam, for the kind introduction, and Rekha Madam for coordinating for this program. Thank you, Vanessa.
Thank you so much, Dr. Manisha.
Thank you, Manisha.
Thank you. So now, sir, we start with the inauguration.
Oh, yes.
So may I have the CV of our chief guest, please?
Thank you, Dr. Manisha.
Sulbha ma'am has not joined.
Yeah, she's there. I can see her.
Okay.
She's on mute.
Ah,
Sulbha
yeah.
madam, unmute karo.
I am there.
Yeah. Very much.
Welcome, ma'am. Welcome.
1+5T.
So it's an honor to introduce Sulbha Joshi ma'am, who's the director of MUHS Fetal Medicine Fellowship Course, Umarji Hospital. She's a retired professor and HOD obstetric gynae, NKP SIMS Nagpur, past president IMS Nagpur, past president Nagpur chapter of BPNI, past secretary Natri Raipur, instructor course of Afprun Mano Marriage Bureau for mental and physically handicapped. That is something new. So welcome, Sulbha ma'am, and we would like your blessings for this webinar.
Thank you, Dr. Asha. At the outset, I express my sincere thanks to Dr. Patel and Dr. Asha for inviting me for today's CME. It's really wonderful to know that today is the 185th episode of this Happy Learning Masterclass. Only Patel sir can do that. Hats off to you, sir, and your team for persistence and consistency in conducting these programs. And it's really my pleasure to be a part of this CME. As far as today's topics are concerned, both the topics are of too much relevance in modern obstetrics. The HDU role of HDU in modern obstetrics. We all know that for every maternal mortality, there are around 120 near miss deaths. And these near miss deaths, they need the HDU treatment. And to talk on this topic, we have an awesome faculty from Nagpur, Dr. Chaitanya. And Chaitanya, I welcome you for this.
Thank you, madam.
I'm very sure. Yes, because I'm seeing him after 2 years. Presently, I'm at Pune.
Very nice.
I'm very sure that our panel discussion, reverse panel discussion on legal issues in high-risk pregnancy, this will be equally interesting with the moderator like Dr. Patel and the learned panelists from Nagpur, Chandrapur, and Bhandara. My best wishes to this episode, this 185th episode of Masterclass series. And I take this opportunity to wish Dr. Patel for the upcoming elections. All the best, sir.
Thank you, madam. Thank you.
Proxy election. Thank you.
Thank you so much, ma'am. Thank you for being with us. And we would be grateful if you can spare time to be with us through the program. We would love
Of
your
course, I will be
guidance.
there.
And may I have the CV of Rekha, ma'am? So Dr. Rekha Rajendra Kumar, a coordinator of this series for a long time, is a gynecologist practicing gynecologist for past 32 years. She is the incoming president of Bangalore Society 2024 to 25. She is an invited faculty of more than 750 state, national, and international conferences.
Thank you, Asha madam. Enough.
I invite you to introduce our guest of honor, Dr. Lakshmi Shrikhande, ma'am.
Yeah, thank you, Dr. Asha madam and MC Patel sir, again for the opportunity. As both of you mentioned, I have been in this sir series since long time, and thank you so much, sir, for that opportunity. I'm really indeed honored and privileged because of that. Again, it is a great job for me to introduce. It's a very, very pleasant task to introduce none other than a person who is very close to my heart. I don't even have to say that it is Lakshmi madam. Madam, so nice to see you here and smiling face all the time. Madam has a very, very rich CV, and probably I have read the same CV many times introducing madam. She's the immediate past chairperson of ICU.
Don't read it, Rekha. Just
only 2 lines, madam.
Yeah.
Fakta 2 lines.
Yes.
National Corresponding Secretary of AMWI. Madam is a President of Menopause Society, Nagpur, Senior Vice President of FOXY in 2012. So thank you, madam, for being here. We are very happy to have you as guest of honor.
Yeah, you can stop the screen sharing. Thank
Yeah.
you so much, Rekha, for your kind words. I'm so happy to Sulva madam, आपका video चालू करो. I'm seeing you after so many years. I'm so happy that she's today's chief guest. And MC Patel sir, you are just 14 episodes short of double century. And I'm sure you will have
We are
the double
approaching.
century very shortly. You will have that double
Yes,
century.
we are approaching.
Yes, yes. And we really wish you all the very best for your upcoming elections. And I'm so happy to be amongst the who's who of Nagpur, Chandrapur, and Bhandara. I will not take names because if I miss any single name, they will feel very bad. But I'm so happy that all the stalwarts from these 3 societies are esteemed faculties of today's 186th episode. And Chaitanya, I'm a big fan of your oratory skills. I must say you are a great orator, and I'm so happy that you are delivering your talk on HDU. So even if I am not doing obstetrics, I am going to listen to your talk on HDU. And what to say, MC Patel is having reverse panel, so you all have a field day. Just go on asking and asking and asking questions to the sir. And high risk pregnancy, sir, we all know it is really nowadays very, very headache as far as medical legal aspects are concerned. And I am so happy that you have taken panelists from all the three societies. They will be definitely asking you very practical problems which they are facing in their day-to-day practice, and you are there to guide us all. So thank you so much, Patel sir, Asha, for making me part of this fantastic web series, and that too for today's 186th webinar. And I wish you all the very best, not only for this webinar, but all your future endeavors.
Thank you. Thank you, Lakshmi Madam, for sparing time to bless us. And thank you, Sulba Madam, also for sparing time to bless us.
Thank you, Lakshmi Madam, for gracing the occasion.
May I have Rajlakshmi ma'am CV, please?
तेच PPH addendum काय लिहिलं तेच लिह ना काय फरक पडतो नाही.
So I would like to introduce Rajlakshmi ma'am. She is a very senior gynecologist and she has the Lifetime Achievement Award from COGS in the year 2024. She's been the best IMA branch national, best secretary IMA, Matra Gaurav Puraskar 2015. She actively supports Beti Bachao. She has a passion for writing dramas and plays. She's written about 20 plays and skits. Drama Mala Jagayche Ahe staged in Rashtriya Vidarbh Sahitya Sammelan. She's passed Sangeet Visharad in Hindustani classical music. She's blessed with 2 daughters. And welcome, Rajlakshmi ma'am.
Namaskar. Thank you very much, Asha madam, for giving such a lovely introduction. But I think I'm all ready for the holy mode. So you see, I'm all dressed up in colors. So since the Ambanis can have a pre-nuptials, we can have a pre-Holi also. So wish you all a pre-term happy Holi. And I'm just waiting to get into the meeting. Thank you very much.
Thank you so much, ma'am.
Thank you.
Thanks a
Thank
lot.
you, Rajlakshmi Madam, for sparing time to bless us. Of course, you are always with us in any of our activity. Thank you, Madam.
Thank you, sir.
Madam, we are so happy to note that your Sangeet Visharad as well as so many skits to your credit. Thank you so much.
That's all past tense. That's all past
trivia for
tense.
us. Whatever. Thank you, madam.
Dr. Rekha, this group that we have, you know, this Nagpur, Chandrapur, Bhandara group, they are extremely talented. Means if I see Pragati ma'am, she is like beautiful in every sense. And most of them, they are doing extraordinary work.
Marathi
with music, with creativity. Means I can't even take the names, whether it's Vedehi or it's Alka ma'am, even Priyanka ma'am, everyone is doing something extraordinary. So
yeah, I know.
we are really proud to be amongst this group. And now I think, sir, with due permission, we'll start the
yes. Oh, yes. Oh, yes. We can.
Today we have really run very fast. So I hand over to Dr. Rekha to introduce our 3 chairpersons.
Yeah. Thank you, Dr. Asha, again. it is my noble task, and I'm so happy to introduce the chairpersons for the first talk. That is the session one is the academic session where Dr. Chaitanya is going to speak, and we have the three chairpersons. Dr. Kshama Kedar, Madam. Her designation is Professor and Head of the Department of Obstetrics Gynecology from Yavatmal Medical College. Madam is a postgraduate teacher for the past 30 years. She has got lot of achievements, a very rich CV, received MS Signature International Award for her service in branding and advocacy of PPH, received many awards. Madam's special interest lies in high-risk pregnancy, HIV, and pelvic anatomy. We welcome you here, Dr. Kshama Kedar, Madam. We are happy that you have chaired the session. Thank you.
Thank you, ma'am.
Yeah, thank you, Dr. Varsha, another dynamic personality, Varsha Subhash Dhavale, Madam. She is the past president of Nagpur 2022 to 23, past president of IMA Nagpur, also lot of awards to her credit, including Nagpur Obstetrics and Gynecology Gold Medal in 2017. She's the chairperson of PCP NDT Committee, IMA. Her special interest in ultrasonography and medico-legal counseling. Thank you, Varsha, Madam. We welcome you here. Hearty welcome to our stage.
Thank you, ma'am.
Yeah, thank you so much. Again, I welcome Dr. Ritu Dhargan, Madam. She is the Director of Integra Specialty Clinics, Khamla, Nagpur, Senior Consultant and Head of the Department of New Era Mother and Children Hospital, Nagpur. She was the Associate Professor of MG, Mahatma Gandhi Institute of Medical Sciences, Sevagram. Welcome, Ritu Dhargan, Madam. I request... Thank you so much, Ritu, Madam. I request Dr. Kshama, Madam, to introduce Dr. Chaitanya, Dr. Varsha to introduce the topic, that is HDU in modern obstetrics, and Dr. Ritu, Madam, to conclude and give her opinion. Thank you. Over to the chairperson to start the first academic session.
Thank you, Rekha ma'am. And at the outset, I would like to thank Dr. Patel, Dr. Asha, and Dr. Rekha for having me on this such an important session and given me the task of introducing our own NOGS star, a very rising star of Foxy, also Dr. Chaitanya Shembekar. He is the past president of our Nagpur OBGY Society. He is the chairman of Infertility Committee of AMOX and Emergency Obstetric Committee AMOX. And he is the clinical secretary of Maharashtra ISAR and MSR 2325. He is the Foxy Endocrinology Committee West Zone Coordinator and recipient of Kamini Rao Yuva Foxy Oration Award and selected by ICOG and Foxy for prestigious Dr. C.L. Zaveri Symposium at AICOG 24. Received MS Signature Award too, and recipients of AMOX V for 3 award at the hands of Honorable Shri Bhagat Singh Koshari at Raj Bhavan. He is a gold medal from Nagpur University, and he is a orations, keynote, and talks in more than 50 Foxy Society. So we have a very eminent speaker, a very good orator, as in Chaitanya. I hand over to Varsha for introducing the topic.
Thank you, Kshama, Madam.
Thank you, Rekha, Madam. Am I audible?
Yes, very much.
Yes.
Okay. At the outset, I thank Dr. MC Patel, sir, and his whole team for conducting happy learning since ages, I can say, because we are crossing the 2nd century now shortly. And I know Nagpur has been in and out of the turns, because last year also we conducted a very good webinar with him. Chaitanya, as we all know, has been a very dynamic person throughout, known as the person who does a lot, many IVF, but now switching over to a quite different topic, I mean, HDU. Yes, that's because he has been really dealing with very, very high-risk patients of obstetrics. I can understand doing IVF on more than hundreds of patients and then managing everything. So he must have been, this is the first-hand experience we are going to get on what HDU in obstetrics can be. So I believe that everyone will be benefited by such a great speaker and in-depth knowledge. So Chaitanya, over to you. I think without wasting much time, we should all be all ears for you to listen what you are going to tell us.
Thank you so much, Varsha. Thank you, Kshama. My special thanks to Dr. MC Patel, sir. I know him since last 20 years, and I know him as a true academician, and more than that, a great human being. And so, sir, we are always with you by all ways. My special thanks to MC Patel, sir, for inviting me and giving me this wonderful opportunity. Thank you, Manisha. Thank you, Rekha. My regards to Sulba Joshi madam, Dr. Asha Jain, Dr. Lakshmi Shrikande, Dr. Raj Lakshmi, Kshama, Varsha, Ritu, and all the dignitaries who are attending this webinar. I bring greetings from Omega Hospital along with Maharashtra SR, AMOGS, and Nagpur OBGYN Society, and Foxy, where I have worked in various capacities. Maternal mortality rate. Where do we stand today? As far as Bharat is concerned, we have achieved a phenomenal 97 MMR, which is actually a big achievement. And Maharashtra as a state is second in rank as far as MMR is concerned. We have 38 as our MMR and Kerala is 19. Of course, Kerala is always number one, and even now Kerala is number one. We have long way to go to achieve this number one rank, but even this second rank was possible because of the hard work and perseverance of all the healthcare workers who are working in various capacities, right from the government machinery to the private sector. So I think everybody is putting efforts to reduce the maternal mortality rate in Maharashtra in particular and in India in general. The Ministry of Health and Family Welfare in 2017 came up with the operational guidelines for obstetric ICUs and HDUs. And we are very proud. It's a proud feeling for us that Dr. Poonam Verma and Dr. Surekha Tade, a very good friend of mine, and Dr. Poonam Verma, whom we look up to as a great academician, they are contributors from Sevagram MGIMS for this operational guidelines which came up in 2017 by Government of India. If you just look at the situational analysis in the medical colleges, and I know that there are many delegates who are attending today's webinar and they are in the private sector. So I am going to analyze both the public and the private sector simultaneously so that we actually can correlate with whatever we are discussing today. So we know that there is an intensive care department everywhere, which is run by either anesthesia or Department of Medicine. We know that ICUs, they are running to the full capacity, and because of the overload of work, there are no beds available for obstetrics. We also know that these intensive care specialists can manage embolism very well, but we also have this problem which is always there in our mind, that they cannot manage PPH or they cannot handle PPH if the PPH happens once the patient is shifted to ICU. So this leads to suboptimal results and even may lead to deaths. And this is possible everywhere, and we face this problem not only in public sector but also in private sector, because ICU people are not trained in managing the obstetric problems. Let us look at the revised health system model, which is actually something which we will be discussing today. So the healthcare starts from the skilled birth attendants. After that, there are basic comprehensive emergency care, and there is a comprehensive emergency obstetric care. So these things, they are taken care of at PHC and subcenters. But at the level of medical colleges, district hospital, and community health centers, we are now having the availability of HDUs and ICUs. So from 2016, for the more robust system of appropriate healthcare at every level, HDU and ICUs are available. So the rationale for this is to develop obstetric ICU and HDU in all medical colleges and obstetric HDU at district hospital level. While we are discussing national guidelines, we will start our thought process as to how to improve the situation in private sectors as well. As I already told you, because many of us are working in private sectors also. So what we are going to discuss in next 20 minutes is how to plan the HDU, how to document the various reporting formats, how to train the medical officers, the staff, the nursing staff especially, and the obstetricians as well. What you need, the equipments and the gadgets. What is your job as an obstetrician? What is your role and responsibility? What are the investigations which you should do? What about the blood bank? And last but not the least is what are the ethics of obstetric care, which is very important, and the problem that the small nursing homes face, because this is something which is important. And can we have guidelines for the small nursing homes as well? So this is the food for the thought. Establishing ICU and HDU, let us talk about the numbers first, number of beds which are actually allotted. So if you look at the medical colleges, if it depends on the delivery load. If the 1,000 and more deliveries are taking per month, then you need 4 beds of ICU and 8 beds of HDU. But the delivery number is between 500 to 1,000, then you require 8 hybrid ICUs where 6 HDU beds are there and 2 ICU beds are there, which we'll be discussing in a short while from now. And from 250 to 500 deliveries per month, we need a HDU which is of 8 beds. Less than 250 deliveries per month, you require 4-bedded HDU. Now, what about private hospital? The question is, can we have the area-wise distribution of ICUs, and can we have 2-bedded HDUs for 30 plus maternity hospitals, which are mid-sized hospitals running only single specialty of maternity or mother and child care, which is now actually there are many chains which are coming up now with mother and child care. So can we have some system for them as well? This is something which we are going to discuss. So what is hybrid model? I have talked about the hybrid model. We know that most of the situations, the obstetric ICUs, they don't work properly because of the insufficient load. We always pray to God that we should not get PPH, we should not, pulmonary embolism is something which we should not never face in our lifetime. That is what we pray to God. And for the same reason, the concept of ICU does not click in many situations. Therefore came the concept of hybrid HDUs or hybrid model, where we have 8-bedded unit, which includes 6 beds of HDU and 2 beds of ICU. So what will happen with this? We have appropriate use of human resources. And since we have mushrooming of ICUs in private sectors, there are many ICUs which are available. Can we have this dedicated unit of 6 beds of HDU and 2 beds of ICU, which is dedicated to obstetric care, so that we can actually do the cost cutting? And this is the situation which is seen in Nagpur also. Therefore, we can do something like a model of hybrid model where 6 beds of HDU and 2 beds of ICU will be dedicated for the obstetric care. Now, as far as the human resources is concerned, HR is also important. It is said that in a obstetric HDU, you do not require an anesthetist. But I think that it is always better to have anesthetist, because anesthetists are many times playing a great role in all our obstetric emergencies, and we cannot imagine, think of working without anesthesiologist. Similarly, you require one obstetrician, a medical officer per unit, per shift, staff nurses, 1 for 2 beds in HDU and 1 for 1 bed in ICU, monitoring and evaluation assistant, which is required for data entry, cleaning staff and guards. So in short, you require 1 anesthesiologist, 4 medical officers round the clock, 16 nurses for HDU and 20 nurses for ICU, M&E assistant 1 each, and cleaning staff as per requirement. As far as the model is concerned, you require somebody who is heading the unit, who is actually coordinating everything, and he is the medical superintendent. He or she is the medical superintendent of the hospital. Then obstetric HOD, who is actually responsible for handling these emergencies, is the nodal officer. And then anesthesiologist and medicine person will be the important stakeholder. So this is how the model goes. And in this model, we have a great role to play by anesthesiologists and medicine persons. And therefore, it is said that daily rounds should be taken by senior, and senior should be a senior physician and a senior anesthesiologist. Also, you should appoint one anesthesiologist as a responsible person, as an emergency focal point, who is best to coordinate all the situations. And here they are already trained in obstetric intensive care. So anesthesiologist who is working in obstetric department or obstetric anesthesiologist is the best person as a coordinator who will be taking care of all these HDUs and ICUs. As far as the diagnosis is concerned, diagnostic workup, you have to have a turnaround time. And this turnaround time is specifically mentioned in these guidelines, where you have to have hemogram and smear for malarial parasite within 1 hour, then other biochemical test within 4 to 6 hours. This is important. This point, timing is very important, because you have, time is running, and when the time is ticking, then you get panic if you don't get the report, because all your management depends on the reports. So histopathology within 3 to 5 days and microbiology within 48 hours is what is the turnaround time. Then they are talking about the blood bank and blood products as well. We all know that blood products are essential in obstetric practice, and here whole blood, as we all know, is nowadays no more preferred. So what you require is blood components. You may have a running component separation unit, but it's a costly affair. However, it is recommended and should be available wherever it is possible. So what are the products which are required in HDU and in ICU? Pack RBCs, yes, of course, you require pack RBCs. Fresh frozen plasma whenever required. Random donor platelets, yes, you require them in ICUs. Single donor platelet to be procured whenever required. Cryoprecipitate you require in ICUs. Whole blood is not recommended, and O negative blood should be available in both HDU as well as ICUs. As the mother is in critical condition, you have to always take care of and think about the newborn. And there should be a guideline which is available for the care of the newborn during the mother's stay in HDU or ICU. Here, decision to keep newborn with the mother depends upon the matter of condition. Obviously, if the mother is critically ill, the baby is either taken care of by the relatives or by the pediatric units. Mothers, if at all they are taking care of babies, they will require additional support to care the newborn. You have to encourage the breastfeeding as far as possible in all the situation, roomed in whenever possible, and pediatricians here have a role too. So here comes the role of pediatrician as well. So we require, it's a teamwork. Anesthetist, obstetrician, physician, and now a pediatrician also plays an important role. So as they are doing regular checkup of the baby. What about the capacity building plan? You need training, and training is extremely important, and that is the reason why Dr. MC Patel has come up with this innovative and novel idea of continuing medical education. His masterclass is attended by so many delegates all over India, and I think even abroad people are always ready to listen to him. So this training part is something which is extremely important. So training includes training of nurses, training of medical officers, and training of obstetricians as well. And here you have to have the basic thing which is important is terminology. The terminology should be taught to all the nursing staff, especially, and the medical officers. Then you have to understand the basics. The back to basics is something which is important, because unless you know the physiology and pathology of pregnancy, you will not know the pathology of pregnancy. So you should know about the drugs in the obstetrics which we are using. You should learn about they should learn about the medical obstetric emergencies, operative obstetrics, wound care, breastfeeding, and the essential newborn care. All these things are to be trained, and here you should let them know about basic things like how the setup is going to run. What about the crash cards? How to operate different machines and equipments which are available in HDU, like ventilators, or even for that matter, the monitors. How to interpret the data. It is also important, because if you know how to handle the machines, you should also be able to interpret the values, and the monitors should be interpreted properly. To learn about oxygen therapy, blood transfusion practice, intubation procedure, the pain management, nutrition of the critically ill mother, basic life support and CPR, and infection prevention. All these policies are to be taught in the training, and therefore the flow of training goes like this. You have to have a HOD OBGYN who is the basic person who is training, along with an obstetrician. Then you require anesthesiologist, and you require intensivist to train those who are ready to work in HDU. So you have to train them by starting with the theory of the emergency obstetrics, then skill stations and observation and hands-on skill stations. Then you should have assisting and hands-on interactive sessions. You should teach them about the emergency drill. And finally, after all these skill stations, you can actually evaluate them by taking examination and give them certificates. Now here I would like to mention about the Manyata and Laksha Manyata. Omega Hospital, our hospital is Center for Skill Enhancement for Laksha Manyata. And this is actually a project of FOXY along with government of Maharashtra. And there are only 6 centers all over India. And we have in the last year trained 54 facilities all over the India and especially in the central India. And this is actually a good achievement because we could train so many small nursing home nurses. This is basically a nurses training. And I must thank Foxy, I must thank Dr. Rishikesh Bhai, Dr. Nandita Parshetkar for giving us this opportunity to run this center, and even Dr. Samita Bharadwaj is there. Why I am talking about this Manyata and Laksha Manyata is because it's my humble appeal to all those who are attending today's webinar. Please, please, please get your center certified if you have not certified your center, because मराठीमध्ये म्हणतात सोनारानेच कान टोचले पाहिजे. Similarly, only the person who is, a good trainer can actually teach the nursing staff. And if you, as a owner of your hospital, try to teach your nursing staff, they may not listen to you because त्यांना असं वाटतं की मॅडम रोजच रागवतात, सर रोजच तुम्हाला आपल्याला रागवतात. पण जर कोणी दुसऱ्यांनी त्यांना शिकवलं, सोनाराने जर कान टोचले, तर त्यांचं ट्रेनिंग खूप चांगलं होतं आणि सिस्टमॅटिक होतं. सो वी फॉलो a protocol, we follow the guidelines, and we systematically train all the staff nurses. And it's a online training program. Therefore, everybody, you can contact me anytime, and everybody must get the certificate of Laksha Manyata for their small nursing homes as well. Now, there are skill stations also available. This includes blood loss estimation stations like eclampsia drill, infusion pump, oxygen therapy, intubation, airway management, ABG method and analysis, and CPR, neonatal resuscitation and ventilation. Here again, I would like to mention you that there is Association of Obstetric Anesthesia, AOA. My wife is anesthesiologist and she is executive member of this AOA, and they are regularly conducting these workshops all over India. So we actually, and we also conducted this webinar this workshop last year. This was a physical workshop. So we can have such workshops every year so that we are trained and we are in touch with the obstetric emergencies, how to handle obstetric emergencies, something which is extremely important. You require mannequins also for the skill stations, and these mannequins are also available, which give you and especially the pregnant mannequin can actually give you an idea about the airway management of the pregnant woman. Then, as far as the training period is concerned, you require 10 days training for obstetricians, 20 days training for medical officers, and you require 31 days or 1 month training for nursing staff. And that is how you can train all the concerned persons who are working in the HDU. And therefore, this is a training part, which is 3 T's is important: train, teach, and transfer the knowledge to the other person. And that is how Jyot se Jyot jalate chalo, prema ki ganga bahate chalo. That is how you should actually learn and then teach many whosoever is interested in working in obstetric anesthesia and critical care. There are various formats which are available. And these formats are important because they include admission register, admission forms, SOFA score test, lab investigation format, progress note, monitoring sheets, discharge cards. All these things are available online. And because of NABH, most of us, we are now well versed with the record keeping, but we should actually download these formats which are available in this website by Government of India, and we should start using all these formats so that medically we are safe. This is the list of equipments which is already given in the website. List of drugs is also available online, so that which drugs you are supposed to keep to manage your HDU is also available online. Now we will discuss a very important point, and that is ethics of obstetric HDU and ICU. And Dr. Arul Kumaran has come up with a very nice his study on the medical ethics and ethics of HDU and ICU. They have divided HDU into 3 categories: level 0, where there is no risk, normal ward, and level 1, where the condition is deteriorating, observation is required, or you may have to relocate the patient. Level 2 is where there is only single failing system, and therefore you require intensive monitoring. But this single failing system is not a respiratory system. So except respiratory system, if other system is failing, you can go for level 1, that is HDU. And then level 3 is ICU, where the advanced respiratory support system is required. And whenever you require advanced respiratory support system, either alone or along with the other organs, then you have to go to the level 3. So this is how you can actually shift the patient depending on the condition of the patient, and that is very nicely given in this article. And one very interesting thing which he has mentioned is about a chain response. So what is this chain response? Try to understand this chain response, because we in our day-to-day practice, we always actually face this situation where the chain response is required. It starts from the non-clinical staff, goes to the recorder, then there is a recognizer, then there is a primary responder, then there is a secondary responder, and finally there is a tertiary responder who is responsible for critical care. So how this chain goes, I will in short try to explain you the chain response. First is the alerter. Who is the alerter? Alerter can be anybody, like it include a woman or a visitor or a ayabai or a person who is doing jhadu pocha. Anybody can become an alerter. If the patient is having some problem, the person will alert the second person, that is recorder. Recorder is usually a midwife, and this midwife will actually not only record the things, will also assist in the further treatment. Then comes the recognizer. This recognizer is actually an interpreter. He can interpret what midwife or nurse is saying. He can be either a midwife or a nurse or a foundation doctor. Then comes the primary responder. Primary responder is the person who starts or initiates the treatment. He can be a junior doctor or a junior consultant. In medical colleges, he or she can be either SR or even JR. In private hospitals, he can be an assistant doctor or even for that matter, a junior doctor. Then comes the secondary responder. Secondary responder is called when there is no response to the treatment. So imagine a private hospital also, there can be a situation where medical officer or a RMO is working. He is a primary responder, he will try to start the treatment. But if there is no response, he will immediately. So call for help is something which is important. We always know that the first thing we do is call for help. So anesthesiologist or obstetrician is a secondary responder. And finally, there is a tertiary responder whose role is to encompass the acute care competencies such as advanced airway management, resuscitation, clinical assessment, and interpretation of acutely ill obstetric patients. He is responsible for advanced management, he is responsible for decision making, and he has access to information. So hospital information is available for him, and usually this person is a trained obstetric anesthesiologist who is trained in handling obstetric emergencies. So anesthesiologist, as you can see, has a great role to play, and Mr. Arul Kumar, Dr. Arul Kumaran has said that a tertiary responder has to be anesthesiologist who can actually handle the is competent to manage the advanced airway management and resuscitation techniques. The rules for the transfer is also something which we all should know. And here, the transfer from a maternity ward to critical care unit or transfer from a small nursing home to a ICU is something which is important. The first thing which all maternity units should learn and should have facility is to resuscitate and stabilize the patient and then to transfer the critically ill patient. So you should have learn to stabilize the patient first. This is first thing which is important. And then the transfer should take place with an appropriately trained practitioner. And this, I think, Dr. MC Patel, Dr. Varsha, and all the medical legal experts are with us today. And we are lucky to have all these experts with us. They will tell you that a person who is transferring is a transfer clinician, and he has to be either a trained obstetrician or a transfer clinician has to be an intensivist, because you may have this problem medico legally. Later on, you may have to face this problem that who was the person who was attending the critically ill mother while the transfer was taking place. So you should be able to answer this question that there was a competent person who you can label him as a transfer clinician who is responsible for actually taking care of the patient during the transfer process. And also, what is extremely important is positioning of this patient, because we are not talking about a normal patient, we are talking about an obstetric patient. And suppose the patient is pregnant with 9 months pregnancy, you have to think about the positioning of this pregnant patient as well, because this may lead to aortocaval compression and may lead to problem. So you should learn to have a good positioning also. Transfer from critical care area to maternity ward. One thing very important is no transfer between 10 p.m. to 7 a.m. If an ICU person says रात को 11 बजे, अरे यार पेशेंट ठीक है मैं ट्रांसफर कर देता हूँ, उसको आपको इमीडिएटली बताना है कि भाई अभी ट्रांसफर मत कर, सुबह 7 बजे के बाद ट्रांसफर करना, क्योंकि 10 बजे से 7 बजे के बीच में देर इज नो ट्रांसफर. Then shared responsibility. Everybody has a share, so you cannot shrug off the responsibility. This is very important. Sometimes we have this habit of shrugging off the responsibility, but ultimately this is who is suffering. It is the patient who is suffering. So you should have a shared responsibility. And what is important is continuity of the critical care of the patient. So this continuity is important. So you should have a written care plan with strict instruction to medical and nursing staff that as to how to go ahead with further treatment, because there is a critical care part which is new or not known to the obstetric ward, and therefore you should have a written care plan as to how to go ahead, and the team should deliver. That is what is the motto. Our motto is to have the smooth transition. What is important is you should not forget that the patient is pregnant. The patient will say, I am pregnant too. Please don't forget that I am a pregnant lady. So the maternity and critical care interface this area interface is important. Wherever a pregnant woman is receiving critical care in an HD or ICU setup, there must be a fundamental principle that her pregnancy care is continued and integrated into overall care plans, and that this continues through to the postnatal period. The multiple caregivers have to ensure that the needs of the critical care do not overshadow the needs of the woman and her family in regard to midwifery or obstetric care, because they need a midwife care also. So you should not forget the role of midwives and the role of obstetrician as far as the patient and her family is concerned. So दोस्तों, थोड़ा है थोड़े की जरूरत है, जिंदगी फिर भी यहाँ खूबसूरत है. ये गुलजार के बहुत अच्छे बोल है, ये हमें जरूरी है. थोड़ा हम लोग कर भी रहे, लेकिन और थोड़ा हमको करना भी है. एंड जाते जाते मैं आपको एक फूड फॉर थॉट दे रहा हूं अबाउट द अनरिकॉग्नाइज्ड प्राइवेट सेक्टर्स एंड स्मॉल नर्सिंग होम्स. Can we together form the guidelines for the small nursing homes? Because standalone maternity nursing homes are still there and they still exist, and they are there in every corner and every lane of every city and every town. In fact, they form the backbone of obstetric practice. Therefore, there is an urgent need to regularize this sector, which is not at all regularized, because government is taking care of PHCs and sub-centers and community centers. But what about the small nursing home? उनका वाली कौन है? उनका वाली कोई नहीं है. इसलिए how to regularize this is a $1,000,000 question. There are two categories. I think there are two categories. This is what is my thought process. That one is a very small nursing home of 5 or 6 beds, which are very commonly seen all over every town and city in India. And there are mid-sized hospitals. Like my hospital is now 50 bedded. Soon it will be 100-bed hospital. So these are the 30+ bed hospitals, which are mid-sized hospitals. So can we have a 2-bedded HDU for such 30+ bed hospitals? And can we have SOPs for small nursing homes where we can have area-wise distribution of critical care units? So you can recognize such centers and officially allot such centers in the radius of say 1 kilometer or 500 meters. And then you can upgrade these ICUs to handle obstetric emergencies. So if you have one center which is allotted to all the nursing homes within 1 kilometer radius, then it may solve the problem. This is the food for thought. So you can start this as a pilot project, and this pilot project can be started anywhere. Now that almost all the faculties are from Vidarbha, we can start this as a pilot project in Vidarbha, and where we can recognize small nursing home, make a list of this nursing home, and we can allot us ICU where we have a dedicated obstetrician who is taking care of the obstetric part, and dedicated intensivist who is taking care of the intensive care plan. So friends, in short, it is ethical for us to respect basic human rights. That is, to preserve an individual's life and health, to provide the care and with dignity, self-respect, and confidentiality. It is also important that the patient and her relative get all the information, and we are involved in decision. They are involved in decision making. You should involve them time to time. You should tell them about the progress and involve them in the decision making. And the women should be provided with the best care which is available, because pregnant mothers are young and they are in their prime of life. Their health and life is compromised due to an obstetric or pre-existing medical complication. If the transient severe illness is overcome, By providing proper critical care, then these mothers will continue to serve as the nucleus of the family and their society. So they are the nucleus of their family, therefore, you have to take care of mothers. I will end my talk with this lovely poem by Robert Frost. The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep, miles to go before I sleep. Thank you very much. Shukriya, MC Patel sir. Shukriya, Manisha. Shukriya, Asha Jain madam, for giving me this wonderful opportunity. Thank you so much.
Thank you, sir. Thank you. As usual, Chaitanya sir has delivered a talk par excellence. And I think none of us can undermine the importance of having an HDU in each and every obstetric setup. And your idea of dedicating a few nursing homes to a particular center would, I think, go a long way in helping a lot of the obstetricians also and putting them at ease while managing high-risk cases. Because when in a small nursing home, an emergency arises, you're single-handedly managing everything. I think you have guided us very lucidly on how to set up a basic HDU. And I'm sure all the attendees here would really benefit from your talk, sir. And I would love to be a part of your pilot project anytime.
Thank you so much.
Thank you. And a big thank you to Patel, sir. Thank you so much for
And
having
we
us here.
stay in the same is we work in the same area, so we
Yes,
can
sir. Yes, sir.
work
Yes, sir.
together.
Yes, sir. Thank you so much.
Chaitanya. It was an excellent one. Even I like your idea of doing for the small nursing homes, because being in a government setup, I have so much of patients and overload of all these patients who are to be kept in HDU. It's really difficult because I have 12,000 deliveries per year. So it's very difficult for me getting everywhere the transfers of all such high risk patients. So if it is better, the small nursing homes, they identify and take care of such HDU patient, that will be very good idea. And yeah, I really appreciate your doing this pilot study. If you really want to do it, go ahead. All the best and very
Thank you
nice
so much.
talk.
Thank you, madam. Thank you.
Probably, Chaitanya, it will make the standalone obstetrics units, doctors to get little more muster, little more courage to manage the patient, so that they'll go one step ahead and make the more of normal deliveries and all that, instead of being very safe and convert to immediate cesarean sections and all that.
Yes, true.
So excellent, Chaitanya, as usual.
Thank you so much, sir. Thank you
It
so
is
much.
a need of time, I would say, because as far as maternal mortality rate is concerned, if we go national scenario, by 2030, WHO and Government of India has given us a target, and it should be less than 70. Of course, you just mentioned about Kerala, about Maharashtra. Gujarat is also doing good, less than 50, 47. But there are few states, and particularly in northern India and particularly northern eastern India, where still maternal mortality rate is near 200. Of course, it has gone down 200, but still it is near 200. And it requires joint venture. It is not work of only one agency. Say, for example, government, NGOs, a federation like Foxy, IEMA, and obstetrician friends who are particularly working in remote area where with very limited resource also, if this high risk pregnancy patients are picked up well in advance, if they are guided where they are to be taken care and where they should be delivered, and if they are transferred well in time, then we can achieve that goal given by WHO and central government. So actually, this is near my heart, I would say, because I have worked in those areas where still it is very high maternal mortality rate in northern eastern India. Till 21 year we go in those area every year for 1 week or so, but it is not enough. To sensitize all our friends who are working in that very area or dealing with day-to-day situation as far as our obstetric problems are concerned, then only we can achieve this. And it is a joint venture, I would say again. So thank you, Chaitanya, for the same.
Thank you so much, sir. Thank you.
Thank you, Chaitanya
Thank you,
sir.
sir.
You know, I like every part of your presentation, except we are actually terrified of more government interference. Right now, the government in Chhattisgarh has taken, means you have to take a permission for cesarean, you have to take a permission for hysterectomy. Now they have sent us papers that for the last 1 year, whatever cesarean you have had, classify as per Robson criteria. They've given a 4-page form, and you're supposed to fill it retrospectively, attach a copy of the partograph, all Indo documents, and submit. So saying that we want to give good care is a very good thing. But how much of government interference do you want? Either the government should employ us all. You know, that healthcare has to be a government subject, finish. You cannot have private nursing homes. And then we are ready to do what you ask us to do, because then we have an infrastructure that somebody else is paying for. Right now, if you have to fill, like Madam was just saying, Dr. Sharma, that she had 1,000 deliveries. If she has to fill 500 forms for cesareans done, how is she going to manage it? And that is the state that has come. So we should do better, we should learn, we should have an HDU, but having more of government interference, I'm really terrified of it. I'm really sorry to say that, but that is the state as it stands now.
Very true.
But here comes role of Foxy, IMA, etc. So I just mentioned that also. It is a joint venture. And if we go with standard protocols or guidelines also, how to deal with this type of cases in that very situation, we are safe. Not
Sir, we are safe, but you know, having too much of government interference, आपको जो भी करना है, right from the staff you employ, कितना पैसा देते हो, कितना घंटा काम कराते हो, and then they don't want you to take charges.
This is
अभी तो जो Supreme Court case से चल रहा है ना, that every hospital charges will be fixed by the government. Now just see how you're going to work with that.
This is
Madam, I agree with you. But actually, even in Maharashtra also, they have started cesarean audit at the government institute also, big colleges. And where it is really difficult, because we all get we are a tertiary centers, and we get all patients as a reference.
That's what I'm telling you. Now, with deliveries happening in government centers, even in the villages, deliveries are happening, cesareans are happening. So the patient that is coming to you is already complicated. And then you have to define the partogram and everything. Retrospectively of 1 year is going to be really tough. So thanks a lot, so much, sir. But please make suggestions. This will be open on YouTube, you know, and then they'll say that doctors have suggested government should do this. So please let us not have more of government interference and more of self-regulation. I think that is how it should work. And thank you so much. And so may I start the panel now?
Oh yes, we can.
We already have so many acts which are already there, and we already have so many forms filling up, like PCP, NDT, additional ART, MTP, so many, and on top of that, these papers.
So thank you so much. Thank you so much for that. And now, sir, we are going to start the panel. It is legal issues in high-risk pregnancy. Sir, it's going to be a bit of a surprise for you as well, because we had more panelists. I added more questions which you don't know about. So I would like to introduce Dr. MC Patel, sir. He is a consultant obstetrician, gynecologist, and medico-legal counselor. He was VP Foxy 2018. He has held many positions, but at this forum, what I would like to introduce him as is he is the go-to person in medico-legal problems for every Foxian, irrespective of a small society, big society, or any position in the society. So he is the go-to person. This is 185th webinar. Consistency is the key to his character. So integrity and consistency, that is MC Patel, sir. You all know him as well as I do, I think. Some would be knowing him even more. He's been working relentlessly for Foxy for the last 15 or more years. So welcome, sir. And
Thank you.
as you all know, he's going for President Foxy this year. And that's me, I've already been introduced. We would hear a short appeal from Sir at the beginning of this program.
शुभं करोतु कल्याणम् आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So here is our panel, legal issues and high-risk pregnancy. I will be introducing the panelists as they come along. So, sir, before we start, I would just like to say that we all know that high risk is high risk. Is it worth discussing from a legal point of view?
Naturally, yes, because as far as any medico-legal issues are concerned, since years together we have observed, and during my medico-legal practice also, medico-legal litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as medico-legal problems are concerned. And if we go with statistics, say for first I would like to mention statistics from USA. 78% gynecologists are the group of doctors who are at least once should in their lifetime as far as medical legal problems are concerned. And 37% gynecologists should for more than 3 times. And same scenario is with a statistic in India also. And particularly when maternal or fetal birth injuries occur or some permanent disablement, then it becomes a potential cases as far as litigation is concerned. And that is why this is a very important issue for discussion, not to end up into this type of litigation or problem. And if at all we are, then how to get rid of this problem is the motto of discussion. Yes. Next.
Thank you, sir. Sir, so we have Dr. Bharat Lanjevar, sir. He could not join, so Dr. Manoj will be taking his question.
Yes, welcome.
He was the president of Bhandara. He is the president of Bhandara Society. So over to you, Manoj, sir.
Hello, good evening,
Yes,
sir.
sir.
Yes, welcome.
Sir, my question is, why litigations are common related to pregnancy and labor? And which are the areas of litigations?
So, as far as litigation related to pregnancy and labor is concerned, so usually these are the group of patients who are young patients. And if anything goes wrong with young patient, whether morbidity or mortality in few of the cases, it is not at all acceptable to that very family. So this is the main problem. Usually they comes on foot. When patient enters in your hospital, they comes on. Of course, there are few conditions. They are brought in ambulance or in a stretcher. It's another story. But usually they comes on foot. Usually they are book patient. Of course, there are few unbooked patient also, but they are book patient. And naturally, we are dealing with two lives, fetus as well as mother. And patient and relative, they take it as a physiological condition rather than pathological condition. So they are not mentally prepared to face any situation which is unwanted or unprecedented, and they have not expected even. So these are the common reason where we end up into this type of litigation.
Sir, the second part, what are
Yes.
the areas for litigation?
So many times a common allegation in related to labor and pregnancy, either diagnosis, it was wrong diagnosis, or delayed diagnosis, or no diagnosis. So this is very common. Unnecessary cesarean, or at the same time one more allegation could be doctor didn't do cesarean well in time. We were not informed properly. Proper consent was not taken. Proper counseling was not done. The infrastructure staff issue. So there are so many areas as far as this litigation is concerned. And nowadays, one more area that exorbitant charge against unwanted result. So this is also one more allegation. And many times there could be when patient was or patient had been to the hospital, doctor didn't turn up to examine patient, and staff took care, and ultimately something went wrong. This is also one area. Or doctor came very late, or emergencies was not properly handled well in time. These are also some areas as far as litigation part is concerned.
Thank you, sir.
Yes.
Now, this is the question for Dr. Manoj Aglave.
Yes, welcome,
He's
Manoj.
a consultant lab surgeon, infertility specialist at Siddhivinayak Hospital, Bhandara. He's the secretary of Bhandara Society, and he loves traveling and book reading. So over to you, Manoj, sir.
Hello, sir.
Yes, welcome.
So, next question to is one book patient, and she conceived after 15 years of active married life with AIT treatment. She was on a regular follow-up with the USG at every visit, and her antenatal follow-ups are normal, except there was a polyhydramnios noted. At 36 weeks of gestation, she turned up with the IUFD, and cesarean section was advised. On routine preoperative investigation, her blood sugar level was 432 milligram per cent. The case was filed against the hospital and doctor, and the compensation was demanded for 2 crore. So in this case, where things went wrong?
Yes, it is very natural that we are expected to advise patient basic antenatal care and basic investigation. And in that very investigation, naturally, we have to go for blood sugar to rule out GDM. Say, for example, to rule out thyroid disorders, and some others investigation, blood group, hemoglobin, etc. But not to advise blood sugar in any antenatal patient cannot be pardoned. And in this very case, before that, when she came up with IUFD, before that, she was very much regular in her antenatal checkup, and no blood sugar was advised or done ever. It cannot be pardoned. So, very important part is we cannot afford to forget to screen patient for all these factors, and particularly high risk factors. So we have to advise all those necessary investigation not to end up into this type of litigation. And one more part is a second part. If at all it is a diagnosed case of GDM, then we have to counsel patient what is GDM, what is consequences or effect of GDM on pregnancy, and if patient is already diabetic, then what is effect of pregnancy on ongoing diabetes. We have to explain everything in detail, and we know sudden IUFD is known in any case of GDM. So we have to counsel patient once it turns out to be a case of GDM about everything related to GDM. Yes, next.
Thank you.
Thank you, sir.
Yes, welcome.
So now next we have Dr. Manisha. She's the secretary of Chandrapur Society. And she does a lot of sports, marathon running, cycling, swimming. She's done her triathlon. She's planning to do decathlon. So over to you, ma'am. Dr. Manisha.
First of all, good evening, everyone. And first of all, I would like to thank Asha Jain madam and MC Patel sir for giving me this opportunity. So my question is, can you share some situations where neglecting symptoms or positive reports of screening can lead to litigation? And what is the importance of protocols and guidelines in case of facing litigations?
Yes. So many a times what happens, treating doctor has never advised for blood group, say for example, and she turns out to be a case of Rh negative. So this type of problem cannot be pardoned. Say for example, forgot to do knuckle translucency or double marker, triple marker, or any marker to rule out Down syndrome or so, and baby delivers with a Down syndrome. And just I mentioned about GDM also, sudden IUFD happens, and we have never counsel about importance of all this care and caution to be taken when it is a case of GDM. If patient has allergy to some drugs, and if we have not inquired about during our antenatal visit or so, or if it is unbooked patient on admission, and something goes wrong. So this type of very common or simple things could be very difficult for us to face in court of law. Many a time what happens, say for example, if it is a case of Rh negative and if it is missed or NTD was required and NTD is not given, if patient is having low amniotic fluid indices and we do not take any action, if patient is known case of preeclampsia, say for example, blood pressure is under good control, but if blood pressure is more than 140 systolic and 100 diastolic, and patient complains of headache, and we take no action, then also it may end up into a problem. Many times what happens, patient is a case of preeclampsia, and we do not advise, or patient is in labor, and we do not advise for liver enzyme test. And if patient turns out to be a case of HELLP syndrome, then also it becomes difficult in court of law to face the situation. And many a time it is usual scenario. Sunday fine morning, evening, you are busy with some guest, or you are watching some movie at home or in theater also, and there is a phone call from your book patient, and she complains that there is decreased fetal movement, and you say nothing to worry, you come tomorrow morning, and when she comes tomorrow morning, it is a case of IUFD. So these are some very common situations we face in our day-to-day obstetric practice, and we should be very careful, because in this litigation problems are concerned, then if, in court of law, it should be seen that we had taken utmost care of that very patient to prevent that complication. In spite of our care and caution, if at all it happens, then it is accepted in court of law. But if we have done nothing to prevent that complication or that very situation, then it is very difficult in court of law to face a situation. Yes, next. Yes, so second question is, what is importance of protocols and guidelines? So when you treat any patient as per standard protocols or guideline, say for example from FOXI, from ICOG, or from RCOG, it is always better, because in court of law you can defend yourself that you had treated patient as per standard guideline, and in spite of all care and caution, this something went wrong. Because I would like to mention one incident which happened in this medical legal problem. So it was 30 to 34 weeks of pregnancy, and patient had a fever, and ultimately patient delivered at 36 weeks of pregnancy. It was a premature preterm delivery, and ultimately baby went CP, and litigation was against doctor. And allegation was torch test was not done. And in this case, a Foxy guideline was given as a defense. And in Foxy guideline, it is mentioned that torch is not routine test as far as antenatal screening profile is concerned. And due to that Foxy guideline, in this case, judgment was in favor of doctor, because inference held by the court was there is no negligence on part of doctor as far as treatment part is concerned. If there was fever in first trimester and to rule out certain infection, if torch was to be advised, it's fine. But in 34, 36 weeks of pregnancy, and when torch is not advised, cannot be considered as a negligence. And case was decided in favor of doctor. So if we go with any standard protocols or guideline, it is always in our favor.
Thank you, sir.
Thank you, sir.
Yes.
Now we have Dr. Sushma Deshmukh. She's the Director, Central India Test Tube Baby Center, President of Nagpur Society. She loves writing books and she is into sports. So over to you, Dr. Sushma.
A very good evening to all.
Yes.
First of all, really, I'm thankful to Dr. Patel sir and Dr. Asha Jain for involving in this wonderful Happy Learning CME. So my question is, unbooked patient, primary 34 weeks with the PIH. She was advised necessary investigations and treatment. But next day, there was abruptio placentae and it was a IUFT. So cesarean section was advised. And the relatives opted for option for a second opinion as usual. So they went to a surgeon in nearby town. A cesarean section was done. There was an atonic PPH and the hysterectomy was done. And the notice was served. So what went wrong and how to defend, sir? Because
so
these things are becoming
this is very interesting case. She was primary, IUFD and hysterectomy. It is very difficult for any patient to face this situation, because primary patient with intrauterine fetal death and hysterectomy, it is not condition which any patient or any patient party or any family will accept. But in this particular case, when she had been to that gynecologist at 34 weeks of pregnancy, and on very first visit, she was found to be a case of PIH. So all the necessary investigations were and treatment were advised. So important is whenever you come across any high risk factor as far as pregnancy part is concerned, say for example here in this case PIH, then you have to advise all necessary and important investigation related to PIH and treatment accordingly. If you have advised all this investigation and treatment, and if patient do not get it done, then it becomes contributory negligence on part of patient. And you have advised all this investigation, all the treatment, and in spite of all this, if at all something goes wrong, then you are out of problem, because you treated that very patient as per standard protocols of PIH. That is one thing. So
Yes,
in this case, a gynecologist should not be held responsible. As far as second doctor who did cesarean section, and ultimately she went into atonic PPH. So in this situation, whenever you face this type of situation, usually few questions are asked in court of law or on part of prosecution. Was it preventable? Was this atonic PPH, or for that first gynecologist PIH, was it preventable? And usually you cannot say no. So one more question will come. What did you do to prevent it? And one more question, in spite of all your care and caution, if you couldn't prevent it, then did you diagnose that very complication well in time? And very important question, did you manage that case way in which any prudent gynecologist would have managed? If you can answer all those four questions, then you could be out of problem. In this case, it was atonic PPH. So here comes importance of management of third stage of labor. And if we can prove by our record, then it becomes easier for us that we took utmost care to prevent atonic PPH. And if at all it happens, Then what did you do to manage this as far as this atonic PPH is concerned? In this very case, it is very known case, and luckily I defended both the doctor, that first gynecologist and second surgeon. So in this, when this atonic PPH happened, that doctor went with oxytocin, ergometrin, prostaglandin. 2 units of bloods were also transfused during surgery, and stepwise devascularization, because gynecologist was assisting him. So internal iliac ligation, etc., everything was done. And in spite of all these efforts, bleeding was not getting control, and that is why hysterectomy was done. So in consumer court, when I was arguing on behalf of both of them, my last sentence of argument was, we have not removed uterus. We have sacrificed uterus to save life of patient. So ultimate result is not taken into consideration in court of law always, but your efforts to save life of patient, in this case to save uterus, were taken into consideration, and both the doctors were saved. Result was in favor of both of them. So we should be careful whenever we are dealing with this type of situation. Whatever we do for patient, it should be well documented, and we should be in a position to justify our action, which we took to deal with this type of situation in court of law. Yes, next.
Thank you.
Thank you, sir.
Yes.
Next, we have Dr. Pragati, who's the secretary of Nagpur Society, and she is all things creative, whether it is dance or creating dramas or books or rangoli or anything creative, and Dr. Pragati has it. So over to you, Dr. Pragati.
Yes. First of all, I really thank to Dr. Asha Jain and Dr. MC Patel sir for making me part of this program. Sir, all of our best wishes to you. We want to
Thank
see
you. Thank you.
Foxy. So here the case is, this is Devendra Nayak versus Dr. Kalyani Jain. And this is a case of C-section. Patient had went into PPH. He had bilateral uterine artery were teared up. Patient was RH negative. And unfortunately, blood was not ready and cross-match was not done by the doctor. And when the patient was shifted in shock to the tertiary care center, patient expired. So notice was served and case was filed. Allegation was not anticipating complications, and procedures or intensive care was not available. So please highlight us, because how
Yes.
to deal.
This is again a known case which happened in city of Ahmedabad only. As such, in this very case, before 4 days of the cesarean section, patient was regular antenatal patient of this Dr. Kalyani, and she advised to go for elective cesarean section with all the preparation for blood transfusion, etc., doing cross matching, etc. But patient and patient relative, they didn't take it seriously. They absconded from the hospital. After 4 days, she had been to this doctor in emergency at 11 p.m. and it was acute emergency. She had no time to manage for blood also, and she went with cesarean section. And ultimately, unlucky on part of that patient and gynecologist too, there was bilateral uterine artery tear, and it was a profuse PPH. She was RH negative, blood couldn't be managed at private nursing home level. Patient was shifted to municipal medical hospital, and on the way, a patient expired. Post-mortem examination was done in this case, and inference held by that person who did post-mortem examination, he mentioned that it was internal hemorrhage due to wrong surgical technique. So this case was decided in long back in 1997. But in this, here comes a question: can person who is doing postmortem examination comment about surgical part? Because he has to simply give cause of death or time since death. But it was due to negligent or wrong surgical technique. And so this type of comment we can challenge in court of law. In few of the cases, I have also challenged this type of postmortem examination. So one good point. in this case, one more point was record were produced by gynecologists. In that very record, there was operative note and note from anesthesiologist. But there was contradiction with note. In operative note of gynecology, she wrote that vitals were within normal limit. And in anesthesiologist, at the same time, it was mentioned that vitals were compromised. So carry home message with this type of situation. We should be very careful whenever we hand it over our record of treatment given to anybody. We should see that there should not be any contradiction between notes given by a gynecologist, any other person who have help in this situation, and anesthesiologist. It should be very clear. And one more point, I mentioned that before 4 days when they were advised elective cesarean section and they didn't take it seriously. So here comes role of negative consent also. We should take consent that we were advised cesarean section, but we are not giving our consent. So this type of negative consent also becomes good defense in our favor, because whatever we advise to the patient, and if patient doesn't follow our instruction, or family or relative of patient are not ready to follow our instruction, it becomes contributory negligence on part of patient, and it becomes good defense in our favor. So these 2 points, and one more point, this inference held by the court was that when patient was Rh negative, blood was not ready. Of course, it was very acute emergency, but anyway, advocate on part of Dr. Kalyani couldn't convince court that she had no time to manage for blood also. But whatever happened, so with this carry home message, if at all we are dealing with Rh negative patient, antenatally, we should be ready to deal with any bleeding problems or hemorrhage problem in future. So we should have a list of Rh negative donor who are known to that very patient. So in any emergency, if blood is not available in nearby bank, because many times as far as Rh negative blood is concerned, it is a usual scenario. So we can avail services from that list, whosoever is volunteer to donate blood. And as far as this Rh negative patient is concerned, whenever we admit, whether it is going to be normal delivery or instrumental or operative, sample of blood should be sent for cross matching in nearby blood bank. Blood should be ready in blood bank. If it is required, then we can put demand on requirement. Otherwise, if blood is not required, we can call to a blood bank that now blood is not required. But at least 1 or 2 units of blood should be ready with nearby blood bank when we are dealing with a case of Rh negative. Yes, next.
Thank you, sir.
Thank you, sir. Next, we have Dr. Priya Shinde, ma'am. She is the past secretary of Chandrapur Society, another very talented and sports-oriented person. So, over to you, Dr. Priya.
Thank you, Dr. Asha Jain, madam. Very good evening to all. My case is also near to that Rh negative. This was the case of 2013. Arvind Pandey versus Dr. Mrs. Sulekha Saran. There was Rh negative group patient. Indirect Coombs test was done. NTT was given at 32 weeks. During cesarean section, there was atonic PPH. Doctor did subtotal hysterectomy also. But there was death at a tertiary care hospital. Sir, where the thing went wrong?
So in this case also, this case was decided in National Commission as far as this compensation part is concerned. And National Commission has very good remark during this case that there was no negligence on part of treating doctor. He had taken utmost care, says, because she gave NTD at 32, 34 weeks of pregnancy. In emergency, when it was atonic PPH, in spite of all her care and caution, when bleeding was not getting control, she went with subtotal hysterectomy. But one comment was passed by National Commission that it would have been better if blood would have been kept ready in nearby blood bank. So again, carry home message with this case also. Whenever we are dealing with this type of cases, particularly Rh negative, the blood should be ready in nearby blood bank. Because during my medical legal practice, we have observed, as far as statistic is concerned, almost 80% of medical legal cases are against gynecologists are related to obstetric problem. And in those cases, 80% are related to cesarean section complication. And out of those 80% are related to hemorrhage, obstetric hemorrhage. So if we want to get rid of this 80% of litigations hanging over, then we should be very careful as far as bleeding part is concerned, or I mean hemorrhage part is concerned. And if we can manage bleeding or hemorrhage and in a very efficient manner, and if we can prove in court of law by our records, then we are saved in court of law in this type of situation. So next.
Thank you very much, sir.
Sir, next we have Dr. Sandeep Nikhade, sir.
Hello. Yeah. Good evening, sir.
Yes, welcome, Sandeep.
Yes, sir. First of all, I would like to thank for giving me this opportunity. And I would like to congratulate Asha Jain madam for taking this extra efforts for organizing so many consultants. MC Patel sir is known for his guidance during any medical emergencies, medical legal emergencies rather. And I can share my experience that once I had a medical legal case, it was not filed, but they were supposed to file, and I called up sir, and he was operating at that time at around 9 o'clock in the evening, and he was busy in surgery. So once he finished that surgery, he called up at around 11 o'clock and guided me for that case. And whatever he said, that saved me from any litigations during that case. So I would like to thank MC sir for that incident. Thank you so much, sir. So
I am
sir,
always, Sandeep, not for
yes,
you,
sir.
you are a good friend, but for any Foxian friends, I am always available to assist them in any given situation. I do remember that very case. Just I finished my surgery, I had a phone call to you directly to
Yes.
tell me what is the problem.
Yes, sir.
Yes,
That's the dedication we want from a leader like you, sir.
Yes.
Yeah. Sir, my question is, there are some situations like if you take a case of placenta previa and a patient is in second trimester, generally we advise them to they can have intercourse during the second trimester. But somehow it was not told by the gynecologist, and then the patient had intercourse and then she had bleeding. So in such cases, how to counsel? And there are other situations like if a patient is in the IUGR and you have not explained them on the paper that what are the risk factors to the baby, and then the patient may told you that you never told me that. And there are some situations like the diabetic GDM patient, and patient went to 36, 37 weeks and then sudden IUD is there. So prior to that, during ANC checkup, we generally tell that everything is okay, and then suddenly such things happen like the placenta previa, she may bleed, IUGR baby, baby may succumb, and diabetic there may be some situation of IUFD. So in such situation, how to counsel the patient and how to whether we should take written consent on our OPD paper or like that. What is your opinion, sir?
So here in this type of situation, it is not important to counsel only, but
Yes,
we
sir.
should be in a position to prove it that we did it or we counseled that very situation. So always in this type of situation, give in writing and have a signature of patient that, say for example, if it is a case of central placenta previa. So what precaution on part of patient should be taken? We have to write and we have to take the signature. One more thing, whenever patient doesn't follow our instruction, I mentioned prior also, it becomes a good defense in our favor if we can prove, because it becomes a contributory negligence on part of patient. many a time you will be observing during your OPD or on admission, a relative who is accompanying the patient will complain that doctor, she is not taking medicine properly. She is not taking proper diet. She is not taking milk. So make a habit to enter in the record. Patient is not taking medicine properly. History given by mother-in-law. Because this simple sentence becomes good defense in your favor whenever you are facing this type of litigation. Because whatever you advise to the patient is patient is supposed to follow their instruction, and she has to follow accordingly. If she doesn't, then it becomes contributory negligence. So we have to prove in court of law that we had advised all these things. So we should be in a position to prove in court of law.
Okay. Thank you, sir. Thank you so much for guiding us.
Yes.
Thank you, sir. Next, we have Dr. Meera Glave, ma'am. She's a consultant gynecologist at Bhandara. Loves reading non-medical books.
Good.
A view of her library. Over to you, Meera, ma'am.
Yes, Meera. Dr. Meera, welcome.
Hello, am I audible?
Yes.
Yes, sir. Thank you, sir. Thank you, ma'am, for this novel panel discussion where we grill the moderators. So now, sir, my case, which is an interesting case of Goel Hospital versus Kishan Gopal Shukla. This patient had a pregnancy with rheumatic heart disease, mitral stenosis, mitral regurgitation, and she was seen by a physician at all time, and cardiologists were not involved. And MTP was not advised, maybe for some reason or the other, and she went in failure at 8 months. The physician advised cesarean section, but the patient died in the ICU within 4 hours. So the NCDRC judgment was given. The cardiologist was not involved. And on the physician, the letterhead said physician and cardiologist. And epidural anesthesia was not administered, and general anesthesia was given instead. And in this case, the judgment went against the doctors, and 7.8 lakhs was awarded to the patient. So in this case, sir, what went wrong?
So this is our observation in this type of situation. So many of our gynecologists have no habit to put stethoscope on chest of patient, and many a time we miss very important situation either on part of respiratory system or in cardiovascular system. And if we have a habit, and if at all we heard any abnormal sound, naturally we have to refer patient to physician, or in view of the condition to the cardiologist. So here comes role of multi-speciality approach. So we have to treat this type of patient when she is known case of mitral stenosis or mitral incompetence. We jointly, or as far as obstetric part is concerned, we have to manage, and as far as our heart problem is concerned, we have to refer that very patient to cardiologist. So if we have involved cardiologist in this situation, then we are out of problem. Yes, next.
Thank you, sir.
Yes, next.
Hello.
Yes.
Hello, sir. This is Dr. Vaidehi. Can I start?
Yeah,
Yes,
yeah.
welcome,
Sorry, I
welcome.
was muted. I'm sorry. Welcome, Dr. Vaidehi. So she is the past president of Nagpur Society, and I remember she even had a recipe book published with all the work that she did. So welcome, Dr. Vaidehi.
Yes, welcome, Vaidhi.
Hello. Good evening, everyone. Good evening, Patel sir and Asha ma'am. Thank you so much for inviting me for this very interesting Happy Learning series. So without wasting much time, I'll just straight away go to my question. So there was this patient who had a regular NC checkup, and in her record of visits in the 9th month, it showed that she had complained of tachycardia and breathlessness, but there was no physician reference given to her. She delivered, and after delivery, patient died 4 days after her delivery due to cardiomyopathy. What must have gone wrong, and what a obstetrician should have done in this case, sir?
So when it is a complaint on part of patient, there is tachycardia and breathlessness, and if you do not involve physician, then how you can be pardoned in court of law? So just I discussed prior also, multi-speciality approach. Whenever you think that there is something wrong with other system, which is not pertaining to us, our obstetrician or gynecology, then naturally we have to involve that specialist of respective uh, uh, discipline. And if we have involved, then it is always good in our favor. So in this case also, no physician reference. So when it is a case of tachycardia, you cannot afford not to involve physician. So
Yes.
in this case, if they would have referred that patient to physician, then it would have been much better. And
This
just
tragedy would have been
prior
averted.
also, yes, I mentioned prior also, if she had put stethoscope on chest, and if she would have find some abnormal sound, respiratory or cardiovascular, and if she would transfer that patient or refer that patient to cardiologist or physician, then she would have been out of problem as far as medical
Definitely.
problems are
So
concerned.
this was a lapse on the obstetrician's part.
Yes, yes, naturally.
Yes, sir. Thank you so much, sir. Thank you.
So next we have Dr. Alka Mukherjee, ma'am. She is also the past president of Nagpur Society. She likes singing, traveling, cooking. Over to you, Alka, ma'am.
Thank you, madam. At the outset, let me thank Dr. Patel, sir. My association with Dr. Patel, sir, is a long way back. And I'm sincerely thankful to Dr. Asha Jain as well. My question is, Dr. Patel, sir, the ANC visit of the patient was uneventful. Her LSS was also uneventful. But 8th day post-op patient was in ICU. She was diagnosed as tight MS, mitral stenosis. Where should we manage such high-risk patients? It's
again
the question of, sir, HDU. I'm asking you about the HDU.
Yes. Again, the same situation. When it was known case of tight mitral stenosis, and when patient was not at all referred to physician or cardiologist, it cannot be pardoned. Of course, antenatal visits were uneventful, fine. Lower segment cesarean section was uneventful, fine. But on 8th post-operative day, the patient had been to ICU because she had a severe breathlessness in this case also. And diagnosis came to be case of mitral stenosis. So if this patient would have referred to cardiologist well in time, then this problem would have not occurred. So the same situation, multi-speciality approach. Whenever we are in a little doubt, there is something wrong with respiratory or cardiovascular system, we have to involve physician or a cardiologist respectively.
Again, a lapse on the part of obstetrician.
Yes, naturally.
Thank you, sir. Thank you so much.
Thank you, sir. Now we have Sharmili, ma'am. Sharmili, ma'am, over to you, please. Ma'am, you are muted.
Am I audible, ma'am?
Yes, you are audible.
Yes, ma'am.
Yes, sir. At the outset, very good evening to everyone, and with warm regards, Dr. Patel, sir, and thanks for involving me in this such a nice program, sir. Thank you, Asha Jain, madam. My question to you, sir, is we have a terminally ill patient, and she's on ventilator and vasopressor support, and the relatives say that we cannot afford anymore. And the intensivist says that the patient is hopeless. So please guide us, sir, how to manage such a patient in that situation, how to manage.
This is very usual scenario in our practice because relative are not interested, or even if at all they are interested, they have no money or they cannot afford. And intensivists say that now case is hopeless and nothing can be done. But in this situation also, you cannot remove life support system because passive euthanasia is not permitted in our country. only one case happened, and Supreme Court has given permission to go for passive euthanasia in case of Aruna Sandbag. Otherwise, passive euthanasia is not permitted in India. So we cannot remove life supporting system in this type of situation, or we cannot write in our case paper, please do not resuscitate. Even if it is a mutual understanding between a relative and treating doctor, and if at all you are going to remove that system, then also you cannot mention in case paper that please do not resuscitate. So this is very tricky situation for us also to manage in this type of situation. When patient has, a relative is not ready to go for further expense, then we can give them option to transfer this patient to government hospital also nearby. And in this type of situation, we can manage. But passive euthanasia is not permitted.
Thank you, sir. Thank you very much.
Thank you, sir. So what I forgot to tell that madam is an avid dancer and does a lot of social work.
Very good.
So she does Kathak and all dance forms. So next we proceed to Dr. Rujita Fouquet, Associate Professor Gynae.
Yeah,
He
very
likes
good evening, sir.
painting, traveling, and reading.
Thank you, ma'am.
Over to
Thank
you,
so
ma'am.
much. Yeah, thank you, ma'am. So very good evening, Patel
Yes,
sir,
good evening.
Asha
Good
ma'am.
evening.
So my question is, it's a story of a young gynecologist, post LSCS. The patient, she has a sudden breathlessness. So amniotic fluid embolism is suspected, and she's shifted to a tertiary care hospital, and she dies after 4 hours. So the relatives, they made a police complaint, and they threatened that they will put a case in the consumer forum. So if the case goes against me and the court award 1 crore, so from where the amount should be recovered? So the question is.
So here comes role of indemnity. In this era of CPA, one cannot afford to practice without indemnity cover, and it should be adequate cover. Many a time in medical legal lecture, question comes from audience that what is the adequate cover? So it depends upon the practice you are doing. If you are dealing with a high risk pregnancy cases in your routine practice, then your coverage should be at least I would say at least 2 crore. Because nowadays, as far as compensation part is concerned, consumer forum courts are awarding compensation in term of lakhs. So 50 lakhs, 60 lakhs, more than that also. In one of the case which happened with Emory Hospital, Calcutta, in Kunal Saha case, so compensation was awarded 6 crore and some lakhs. With interest, it went up to 11 crores and some lakhs. But in that very case, a treating doctor were awarded very nominal compensation in 10 lakhs or so. But rest of the amount was to be paid by Emory Hospital. But in this situation of this era of CPA, we should have adequate indemnity cover not to end up into problem in this type of situation. Because in this very case, it was very young gynecologist. He had started practice a few months back only, and this situation happened with him. It was amniotic fluid embolism. In spite of all his care and caution, he resuscitated patient well. Patient was transferred in nearby ICCU unit, but during course of treatment, a patient was expired. And we know, as far as amniotic fluid embolism part is concerned, of course, it is rare condition, but as far as mortality is concerned, it is almost 50% of the. So we can be saved in this situation as far as litigation for compensation is concerned with indemnity cover only.
Thank you, sir. I think that's a very important take-home message that the indemnity insurance should be there with everyone. Thank you, sir.
Sir, I had a question, Patel sir.
Yes.
Regarding indemnity, many doctors, they get insured from 2 or 3 sources. So can they get reimbursement from all of
No,
them?
No,
only one.
usually whenever you are dealing with any case in court of law and you have mentioned in court that you are covered with that very insurance company should be made party. I would advise as a medical legal expert, in that very case, insurance company should be made party, and whenever compensation is awarded, if at all we lose the case and compensation is awarded, then direct order will be from consumer fora to pay compensation from indemnity company only. When more than one company is involved, then other company may have excuse that that company was taking care as far as litigation party is concerned and facing in court of law, and we are not going to pay, and you cannot do nothing. I mean, you cannot do anything. So whenever you have more than one coverage, at least there should not be more than one company for coverage. Only one insurance company with adequate coverage enough. So this is a carry-on message. That
Thank you,
when
sir.
you involve more
Sir,
than one, they are not ready to pay.
thank you, sir. Next, we have Dr. Kirti Sane ma'am, who's the past president of Chandrapur Society. So she is very fond of music and reading. Madam is out of station, so her voice might not be so good. Over to you, Sane ma'am.
Good evening, all, and thanks. You made me a part of this panel discussion. Thank you, Patel sir and Asha Jain
welcome.
madam.
Welcome.
Thank you,
The
ma'am.
situation is transfer of patient. What will decide where patient is to be transferred? Would you like to confirm with proper person where patient with patient discussion something about escort of patient, discuss
Yes.
about transfer
Yes.
documents.
So
The
as far as
situation is very tricky.
Yes. As far as transfer of patient is concerned, because there many a times we have to take decision to transfer patient to another hospital or higher center in view of the condition. So where patient is to be transferred, we can give all the options available nearby to the patient and patient party, but ultimate decision would be on part of patient and patient party only. Of course, if whichever decision they have taken and if it is not good for them, we can advise. Let's say, for example, if ventilatory support is required and we are referring patient for ventilatory support, and where they have decided to go and ventilatory support is not available there, then we can advise. Then it is not better option for them. And one thing, always confirm availability of bed, availability of operation theater, ventilator at that very hospital where you are referring the patient. Because many times when patient reaches there and patient is in need of a ventilatory support and ventilator is not available, patient will have to be shifted to another hospital and precious time is wasted. So it is very important point. One more important point is escort of patient. Escort of patient in the same ambulance with all emergency drugs, etc. Preferably, doctor should escort the patient. But if doctor is busy with some other emergency, then equally competent person can also escort the patient. And in this situation, anesthesiologist is the best person to escort the patient. If anesthesiologist is also not available, then your trained staff also can do. Somebody should escort in the same vehicle because they can take little care, whatever care they can on the transit if at all something goes wrong during transit. Say, for example, if it is a case of eclampsia and you are transferring patient to higher center, and if somebody accompanying the patient and see through one more fit, then that can be managed at that level. So once somebody should be there to escort the patient, but in the same ambulance, because in one of the cases which happened in city of Pune, doctor was escorting the patient, but doctor was in his own car, patient was in ambulance, and during transit, patient suffered heart attack. And in spite of all measures, patient couldn't be saved. So allegation on part of patient relative was the same. Doctor was in his own car, so patient couldn't be saved and couldn't be taken care immediately. And in that very case, decision was against doctor. So whenever you escort patient, you should be in the same ambulance.
Okay.
Thank you, sir.
Thank you, sir. Thank you, sir.
Next, we have Dr. Maushmi Tadas, ma'am. She is also from Nagpur and she likes reading, writing, and dancing. So you can have a look. So, welcome, Dr. Maushmi. Over to you.
Thank you, ma'am, for a kind introduction. And good evening, all of you. Thank you, Patel sir and Asha ma'am,
Yes,
for
welcome.
making me a part of this program. So I would like to directly go to the question. Patient was taken for cesarean. She had a large uterus and she has a condition called thalassemia minor. The baby was delivered, which was uneventful, but there was a gush of bleeding before the closure of the uterus. So blood was started in OT, and after 15 minutes, the patient had cardiac arrest. The cardiac arrest was managed, and her blood was stopped, and the patient was shifted to post-op ward. Then the relatives were explained, but they started creating a problem, and they reported that wrong blood or mismatched blood was given to the patient. So what should be done in such situations? So that should we take always that consent before giving blood, or what should be done? Please guide us, sir.
Yes. So first thing, whenever you are planning for blood transfusion or when it is needed, then separate consent for blood transfusion is very much required. If at all you are going for cesarean section and blood is to be given, then one consent for cesarean section, one consent for anesthesia, and one consent for blood transfusion is required. So one will ask why separate consent is required. Because in one of the cases, the court has very good remark that surgery involves risk and blood transfusion involves additional risk. So separate consent for blood transfusion is also very much required. As far as allegation that wrong blood was given or it was mismatched blood grouping or so. So in this case, how you can defend yourself? Naturally, how you confirm that the blood which is supplied by the laboratory is for that very patient. Label on a sample of blood, name of patient, a group of patient, date, when it was supplied from laboratory. Everything is written on that very bottle, and one report is given to the patient. So you have to compare that blood details on the blood bottle and with report, because you have only measure to confirm it. Other than this, you have no measure to confirm that blood which is demanded is supplied for the same blood group also. And in court of law, if you can prove that you had examined this label, etc., then you could be out of problem. Because in this situation, if at all wrong blood is supplied from a laboratory, then that laboratory will be held responsible. But for that, if at all when this blood reaction occurs, you have to go with blood sample from patient and sample from that bottle of blood which is left little. Because in any blood transfusion, we always advise that some blood should be left. Because in this type of situation, you have to send both the sample to the laboratory to confirm whether it was mismatch blood transfusion or there was some blood reaction also. So if you do like this, it shows your concern that you have taken utmost care to save life of patient and you are saved in court of law.
Thank you, sir.
Right,
Yes.
sir, right.
Yes.
So
Now we have Dr. Priyanka Kamble, ma'am. Yes,
Asha,
Dr. Maushmi.
Maushmi wanted to say something.
No,
Yes.
no, it's okay, sir. I just wanted to say
Okay,
that
fine.
whatever hurry we may be in managing the patient, we must follow these small tips that the blood grouping and the label should always be checked, and it should be
Check the label and sign that check
signed, yes.
by.
But checked by
You
sign,
have checked.
yes.
Sign, date and time. At
Yes.
what time and on which date you check that very sample and that certificate.
Yes, and many a time that work is done by the anesthesiologist, so we must instruct them also.
No. Even if he can also but he will have to sign that paper that he had
Yes,
checked
yes.
the blood sample. Then
Right, sir.
fine. Anesthesiologist can also check, no issue.
Yes. Right, sir. Thank you, sir.
Yes.
Thank you, sir. Now,
Yes,
last
Priyanka
we
madam,
have
welcome.
Dr. Priyanka Kamble, ma'am.
Yes, welcome,
So
madam.
she is the past president of Nagpur Society, and in her tenure, she likes dancing, touring, reading. The society won the DK Talk Trophy, and she has also started a gold medal for gynec-oncology in Nagpur Society.
Very good.
So, over to you, Priyanka, ma'am.
Thank you, sir. My battery is low, that's why I was in hurry. Thank you for giving me this opportunity, and my best wishes to Patel, sir. Thank you, Asha Jain, madam. My question for Dr. MC Patel, sir. Patient admitted in emergency at 2 a.m. in labor with history of trial for delivery at home for almost 36 hours. Lower uterine segment was stretched, Bandel's ring was present, obviously obstructed labor. Fetal heart sounds were irregular. Consent was taken, LSCS was done, and she had PPS, 2 blood transfusions were given. Baby needed resuscitation. The baby shifted to NICU. Baby had convulsions, and the baby died after 3 hours in NICU. Now the relatives are creating ruckus and destroying the hospital property. So what went wrong, and basically how to prevent? Over to you, sir.
As far as that part is concerned, that patient, relative were destroying the hospital property, you have to inform police in that very situation. And if you have rush team in your society, then you have to inform member of rush team. So member of rush team will also be at your rescue, because we have very good experience in city of Ahmedabad only. We have rush team in Ahmedabad. Ahmedabad is big city. So in each area we have rush team. In one of the cases, in one of the hospital rather, it happened that relative were making this type of miscreants, and simple message was put in that very group. You won't believe, more than 100 gynecologists at that very hospital within 1 hour. So this is very important to have a rush team in our society to avail services in this type of given situation. Inform police whenever they are destroying property or so. But these are the potential cases as far as litigation is concerned. So naturally they will go with litigation, and we will have to prove that we had taken utmost care of that very patient in that very given situation. And we can prove it by our records only. When patient had been to us at 2 a.m., cesarean section was done, whichever care we took for that very patient to save life of patient, we have to mention everything in record. And if you can prove in court of law that whichever care was supposed to be taken by you and you have taken, you are out of problem.
Just to say one
Sir,
thing.
actually, what happened? This was a real case that happened.
Yes.
It is in a periphery hospital. Now there
Yes.
are no other hospitals there, and their doctors, they informed the police. Because the baby died, the relatives had 2 questions. Why did you do cesarean? You have stopped her, you spoiled her obstetric history. You should not have done cesarean.
So
that was one thing. And why the baby died. So they were not ready to listen to anything, and the police was over smart. It took the doctors and kept them in lockup till 4 p.m. the next day. And when here the IMA got activated, we got news, and everyone started, pressurizing the DGP and all. They said, we have kept the doctors in custody for their safety. And they kept those doctors in custody till 4 p.m. without food, water, anything. So how to prevent this?
So in this type of situation, you can approach higher authority. Just to mention, you approach DGP or so. The same incidents was happened in city of Ahmedabad only. And in that very case, when we approached DGP fired that PI in a very bad manner. That how you can deal with doctor in this situation, because there are guidelines given by Supreme Court in famous case of Jacob Matthews. So how doctor can be arrested or should be arrested in this type of situation? How police can decide that it was prima facie negligence on part of treating doctor? So they are required to have an opinion from equally competent doctor that whether doctor was negligent in treating that very patient in that very given situation, and it should be non-biased opinion. So if police has not done this and police has over-exercised their power, then they can also be held responsible. In one of the cases in Supreme Court, Mohammad Ishfaq case, Justice Kaju had very specifically mentioned that line also. Police can also be prosecuted if they have over-exercised the power. So in this situation, here comes role of RUSTIM, just I mentioned, and role of IMA, role of FOXI, the member society to help our Foxian friends in given situation.
So I had messages from two doctors that they want to ask questions. So I request, please ask your questions.
We allow.
Sir, we have 10 minutes. So
okay, no issue. Then we can.
Dr. Rijuta, you wanted to ask, and there was one more person who wanted to ask questions.
Yes, Rijuta, welcome. Yes, Dr. Rujuta.
She's gone away, sir.
No issue.
Can't
she
see
has
her anymore.
question in chat box.
No, sir. Should I read it? She sent it to me by message.
Oh yes, you can.
Okay. Just a second. I'm opening my WhatsApp.
So before you
So her question was that when double marker facility is not available in government setup, can it be medical negligence if we do not advise a double marker in government setup if the baby has turned out to be Down syndrome?
We have to advise because as far as any advice on part of treating doctor is concerned, we have to advise. But when it is not possible and not getting done by patient due to any reason, it is not available in that very hospital, or we can refer patient to any other center also. But we have to advise. If we have not advised at all, merely on that ground that it is not available in that very hospital, cannot be pardoned in court of law. We have to advise.
Okay. Thank you, sir. So I think that's the end of it.
Yes. So
any other questions from anyone?
Yes, we will entertain. But before that, as far as we were discussing about the transfer of patient, etc. So I would like to mention on FOXI website, FOXI uniform consents are available. We three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consents. Say for example, consent for cesarean section, consent for hysterectomy, abdominal, vaginal, endoscopy. In that very consent for anesthesia, consent for blood transfusion, consent for termination of pregnancy, medical method, surgical method. In that those consent, we have prepared how to transfer patient to higher center and which kind of caution you have to take at the time of transferring the patient, which kind of transfer documents we have to produce and to give to patient party. So everything is given in FOXI website. So you can go through, and now it is available in Marathi also. So you have to simply download and utilize in your day-to-day practice. And this is my humble appeal again to endorse my candidature for post of President FOXI election year 2024. Considering my seniority, sincerity, dedicated work in FOXI for years together, and easily and readily availability to deal with situation in any odd situation to be helpful to any of our FOXian friends, I simply appeal to vote and support me in my journey to election for President FOXI election year 2024. Election would be from 1st August to 10 August. And in the same election, Dr. Asha Jain also contesting for post of Chairperson, Food, Drug and Medico-Surgical Equipment Committee, FOXI. Her election would be from 16th of August to 25th of August. But before that, in month of May, each society will nominate our candidature, and in month of August, they will have to vote. For me, all the Foxian are voter, A category and B1 category. And for Dr. Asha, society will vote and some other voters are there. So it is humble appeal to support candidature of myself and Dr. Asha in incoming election. Thank you. Thank you very much.
Thank you so much. Please vote and support for, nominate us and please support us. Sir, Dr. Sharmili had a question.
Yes,
Dr.
yes,
Sharmili ma'am, you may unmute
welcome.
yourself.
Welcome.
Sir, her question was, she wanted to ask a question on tubectomy failure has come for MTP.
Yes.
Ma'am, if you would dilate on that, you haven't explained more than that. She has written, tubectomy failure comes for MTP, then what is the problem? Is there any legal issue involved in that?
No. Yes. If your center is registered, you are qualified person, you can terminate pregnancy. So there is no issue as far as termination part is concerned. As far as failure of sterilization operation is concerned, if patient sues you, if you have operated for the sterilization, then there are so many judgments in court in favor of doctor, because failure rate is accepted 3 to 4 per 1,000 surgery. But how you can defend yourself in court of law? By your operative note, that you have taken utmost care at the time of surgery and you had operated that very patient as per standard method, say for example modified Pomeroy method or any other method you have went with. So you will have to prove it by operative note. And one more part is your discharge card. So in discharge card also you will have to instruct everything, that there is possibility, and at the time of consent also there is possibility of failure in female sterilization operation in 3 to 4 patient per 1,000 surgery. So you have to mention in consent also. And at the time of discharge, when you give instruction to the patient, you have to mention that if at all you miss the period, then you are advised to contact hospital immediately. So we can deal that situation accordingly. If you have gone like this, then you could be out of problem. There are so many cases decided in favor of problem.
Thank you, sir. Yes. I hope, Dr. Sharmili, you are muted. I hope that answers your question.
Any other delegates or faculty, if time permits, they have their comments or question, if at all. Yes, Vaidehi, any comments? Vaidehi?
No, sir. Hello. No, sir. Thank you so much. It was a very, very enlightening and a very informative webinar.
Yes, thank you.
Many of our questions got solved.
Yes, thank you.
And our bestest wishes, sir, to you. Our always ever ready, ever cooperative, always accessible candidate, sir. That is you. And best wishes to Asha ma'am as well.
But you all will have to
thank you so much.
And all the delegates who have joined this webinar, from your society, no vote should remain unvoted.
Yes,
so,
sir, definitely.
Nagpur, Bhandara, Chandrapur, and any other society who have joined this webinar.
We'll ensure that, sir. Thank you.
Thank you.
Thank you, Dr. Vaidehi. So, sir, should I give the formal vote of thanks?
Oh, yes.
So, thanks a lot, all the respected faculty, and I'll have to take all names then. So, I thank everyone who has attended this webinar, all the delegates, all the faculty, Corona Remedies Abhishek, who have been part of this. I thank Chandrapur, Bhandara, and Nagpur societies for sparing a very precious evening with all of us. Thank you, Sulbha Joshi ma'am, Dr. Raj Lakshmi ma'am, Dr. Lakshmi Shikhande ma'am, for being our guests, and also Dr. Kshama, Dr. Varsha, and Dr. Shama, Dr. Varsha Dhaule, and Dr. Ritu Dargan for being our chairpersons. I thank MC Patel, sir, for having this whole series and giving us all an opportunity to join in the evening and learn something new. I also thank Dr. Bharat Lanjewar, Manoj Aglave, sir, Dr. Manisha, Dr. Sushma Deshmukh, Dr. Pragati, Dr. Priya Shinde, Dr. Sandeep Nikhade, Dr. Meera Aglave, Dr. Vaidehi, Dr. Alka Mukherjee, Dr. Sharmili, Dr. Rujita Phuke, Dr. Kirti Sana, Dr. Maushmi Tadas, and Dr. Priyanka Kamble. I thank Dr. Manisha Ghate ma'am and Rekha Rajendra Kumar ma'am for being with us all evening. Thank you so much. See you again next Tuesday with a fresh topic and new artillery for medical Ibru cases. Thank you so much.
Thank you.
Thank you,
And thank you, Manisha,
madam.
particular for helping for this webinar.
Yes,
Thank you, sir.
yes,
Thank you,
sir. And
madam.
all the best for you, Asha
Thank you.
madam and
Thank you.
Patel sir.
Thank you.
Please.
Thank you.
Thank you.
Thank you.
Thank you.